Good evening, everyone. Thank you all so much for joining us. We're going to give people a few minutes to join. I'll quickly introduce myself. My name is Edith Bracho Sanchez. I am a primary care pediatrician here at Columbia. I'm also part of the external affairs team that, as you know, puts these webinars together. We are so excited for our panel of experts this evening. We're going to be talking all about resilience and ways to foster it in early childhood. Before I introduce them, just to give everyone a second to hop on the Zoom, I want to remind you we have a very exciting CME course happening this weekend. It is the 10th annual specialty updates for the general pediatrician. If you haven't registered, you still can. You can just scan the QR code that you see on your screen right now. We're also going to send an email with resources after this webinar, where we'll send you the link where you can register as well if you happen to not be able to scan this right now. But it really will be an amazing 2-day event that you can tune into after the fact if you're not able to join live. We also have a podcast here at Columbia Children's Health that you can listen to now. It is called The Stuff That Matters for Kids Health. I host it. We have an amazing group of experts for our first season, which is out now, wherever you listen to podcasts, or you can scan the link on your screen. And we're also on social media at Kids at Columbia. We're putting a lot of work into our socials, so we hope you follow us, including our LinkedIn, by the way, which is very recently launched. So now that we're a couple minutes in, I do want to go ahead and introduce our amazing panel of experts. First, we have Dr. Dani Dumitriu. She is an assistant professor of pediatrics and psychiatry at Columbia and the director of the Nurture Science program. We have Dr. Beth Maletz, who is an assistant professor of clinical nursing at Columbia and the behavioral health co-lead for Maternal and Child Integrated Mental Health program at NYP, which we rely on heavily in our practices. We also have Dr. Evelyn Berger, who is an associate professor of pediatrics at Columbia and the pediatric champion for the HealthySteps and Family Peace programs. And I already introduced myself. Very quickly, quick disclaimer about the information that we're going to be sharing this evening. The content on this webinar is really provided for general information only, should not be relied on as a substitute for any professional medical advice or treatment. And the views that we're going to be sharing are solely a reflection of the expertise and experience of me, who was your host this evening, and our panelists. So very briefly, I want to start, and I'm going to stop sharing my screen. I want to start just at the beginning with some definitions. I think starting with defining what we're talking about is really helpful as we engage in this topic. So I want to start with you, Dani. When we talk about resilience, can you explain really what it is and what we know about where it comes from?
Yeah, I'm happy to. Well, in terms of research, it's actually interesting that there's not a lot of researchers that agree fully on the definition of resilience, but the one that I like the best is that resilience is an active coping mechanism, which the reason I like that a lot is because some people think of resilience sort of colloquially as the absence of responding to a stressor. But in the research that we're doing on this, we're finding that those individuals that are resilient are, in terms of both animals and humans, are the ones for whom there's the most happening in their brains. Their brains are active. There's protein synthesis in various parts of their brains. So it's a very active process. It's not the absence of actually responding to an insult, but it's an active ability to respond to that insult in a healthy way. That's probably my favorite definition. The other, piece to this that we're finding more and more in terms of research is that resilience is also very specific to the stressor. So people that are resilient to particular kinds of stressors are not necessarily resilient to all kinds of other insults, right? And so there is a lot of context dependence. And in my lab, what we're studying is sort of two very different types of resilience. One is individual resilience, which is that grit of like, I'm going to do it. And then there's social resilience, which is the ability to to stay in close relationships with others, despite insults like, for example, being bullied or other things that involve a social context. So those are, I think, the main pieces of resilience that I think about.
Yeah, and I think right off the bat, Dani, you're giving us so much to think about beyond just the definition, right? You're adding some really important caveats, like, yes, it's this ability to adapt and but it also has to do with the context of the stressor and the social and the community that we build around different things. I want to just quickly remind people that we can see your questions if you type them into the Q&A. So feel free to send those throughout our conversation if something comes to mind. We also will leave some time for questions at the end. But if, as we're talking, you think of a question, definitely feel free to put it in the chat. Beth, I want to go to you and ask you a little bit about the role that resilience has in mitigating adverse childhood experiences. And I wonder if you could just explain briefly what those are, those adverse childhood experiences. Some of us have learned to know them as ACEs, right? So what are those, and what is the role that resilience is known or thought to play in mitigating some of those experiences, knowing that there's so much more that goes into that mitigation?
Absolutely. Thanks for having this conversation. It feels so important to me, and I'm really glad to be here. So in terms of adverse childhood experiences, or ACEs, as you acknowledge, we do call them often in healthcare. These are experiences that happen to children, and they are sort of objectively difficult or negative experiences that can happen. And they could be, they have the potential to be traumatic, meaning that they can really have lasting impacts on the child. So these are the kinds of experiences that can place the child in danger or provoke fear or sadness or worry. These can be like concrete, distinct experiences like abuse or neglect. These can also be, more in a social context, witnessing violence in the home. And, unfortunately, that's one of the things that we more recently have seen a big uptick in. I think families are under tremendous stress right now. So seeing interpersonal violence in the home and witnessing that among family members is something that children might experience. It could also be, more sort of chronic and cumulative experiences, having a parent with an untreated substance use or mental health disorder, and a child maybe seeing them struggle in that way. These are the kinds of things that we sometimes call toxic stress, meaning that over time they really can impact the child because they're living in this setting of experiencing a lot of stress over time. And again, these all in young children have the potential to lead to what we call internalizing behaviors. So those are when children might feel very sad or scared or worried, maybe withdraw a little bit or have difficulty sleeping. They can also lead to more externalizing behaviors like tantrums and acting out and more of those bigger displays of difficulty that we see young children having. And the science has really shown that these ACEs over time can lead to all sorts of difficulties for people. So lots of health problems, cardiac problems, neurologic problems, but also people's ability to function in society and, have healthy employment and relationships and all of that. So, there certainly is the potential for these ACEs to have lasting negative impacts when they happen to children. The wonderful thing, as you heard Dani talk about, is this notion of resilience. And I love the way you described it, Dani, as this sort of active process. And when we think about resilience in children, again, it's not that they're not impacted at all by these experiences that happen to them that might be scary or unsafe. But they maybe have a moment of feeling that, but they're able to recover, and they have some healthy adaptive responses and skills that they can use. So they can, we think of kids as sort of being able to bounce back and not let these setbacks be their only story or their only experience. And so, kids might have these ACEs, but still be able to learn and grow and develop and be social. Again, they might have these moments of sadness or anger or frustration, but overall, their trajectory is still a positive one. And so there's a lot of things that we know that can foster resilience, and I'm excited that we'll talk more about this as the webinar goes on. Some of the things are healthy relationships. So, in the midst of some of these ACEs, if children have a supportive family or other caregivers around them who can help them through that, if they themselves are healthy and have some, good mental health and wellness resources, if they feel like they have a sense of purpose and they belong, and if they feel good at things, if they feel what we call self-effective, meaning that they can master certain skills and be the kind of kid that they want to be. Those are those resilience factors that we really hope to develop in young children.
Yeah. And I'm excited to talk more about those. I wanted to round out this section and sort of talking about some of the definitions and what we see on the ground about the potentially negative, very real negative effects that some of these experiences can have. So Evelyn, to ask you as a physician, tell us more about those real life consequences, right, of these adverse childhood experiences when not mitigated, when not addressed, when, sometimes not prevented, right, by the various systems that we have set up. So what are some of those negative experiences or negative consequences, I should say?
Yes, thanks so much, Edith, and everyone. So, I mean, as a general pediatrician, as parents, as physicians, we monitor children as they grow, and we're watching them develop skills and language and, positive interactions with people around them. When children are affected by stressors, such as those described already, their developmental progress and their attainment of those skills can be disrupted. And so often we'll see developmental delays. Things like language can be disrupted just because they haven't had the opportunity or the setting or the ability in which to learn those skills. So developmental delay is a big one. Behavioral problems, as Beth mentioned, is of another big one. Often the brain is just, as Dani mentioned too, on overdrive. There's parts of the brain that are just the alarm parts that are triggered, so that if they're constantly in fear, they don't have the time, the space, or the ability to develop some other parts of the brain. So the thinking part, the concentrating part, the learning part, and sometimes those look like things like attention deficit disorder, some of the internalizing and externalizing conditions that Beth mentioned, we'll see. And it's not necessarily that they have ADHD, but they're showing these behaviors just because of the way that their brain is functioning. There's physiologic things. And so in the very young, who are really dependent on their caregivers for things like routine, support, bedtime, just figuring out as a very young child how to have a schedule, how to figure out how to behave and how to live your life. When those things are disrupted, they'll have a lot of trouble sleeping. Hormonally too, they'll have that anxiety. So sleeping and eating, tantruming, toileting, those things are affected as well. And so as pediatricians, as parents, we see these things that are common and often think, what's wrong? Something's wrong. And I know a lot of us have used these terms now instead of thinking, what's wrong with this child? Do they have a diagnosis or something that we need a medicine for, a diagnosis for? Really, it's about asking more what happened in their environment and maybe disrupted their normal development or typical development. And can we go back and sort of put some of those things in place to allow them to be able to develop some of that routine, some of those skills? Interpersonal things is just the last thing I'll say, and Beth mentioned it, is that sometimes we see kids who have trouble socially and, being a middle school kid, a kid who's learning how to interact with their peers, a teenager. I know we're talking about early childhood, but from the very beginning, if there's a lot of fear, stress, or environmental factors that make it hard for children to develop those social skills and interactions, there'll be a lot of interpersonal problems. So these are the typical things we see.
Yeah. And I think there's, of course, so much in what you just said. I think, the moment that I sort of changed my own thinking is this framework of, going from the what's wrong with this child to what happened, right? I think that pivot is an important one for so many of us who encounter families who are going through a variety of different things, right? Some in the family, some external, some, just a lot of different things. And I want to ask you, both about some of the programs and the work that you've done, but I do want to talk a little bit more about the science before we move to talking about some of the programs that we have available to address some of these things. So to go back to you, Dani, what does your research specifically, because you do a lot of research in this, show about the ways that we can use our understanding of biology to foster resilience?
Well, one of the so I want to mention to everybody in the audience that I actually primarily have worked in resilience in terms of animal models. And so it's a bit of an indirect answer that I will give. But, one of the things, the concepts that I want to really bring in here is that the absence of stress is not the solution. It is the type of stress that we are talking about. And both Beth and Evelyn, mentioned a lot of what can happen with toxic stress and the ACEs, the adverse childhood experiences that children can have. But that's the bad stress. The absence of any stress is actually probably more problematic than the presence of really bad stressors. Stress is a normal part of our physiology, right? The reason we have these circuits in our brains is because thousands of years ago, when we were hunter-gatherers, we needed to run away from lions, for example, right? And that activation of the stress response is a critical component of survival of any species. So removing all stress is not the solution. In fact, good stressors, things like competition, things like studying on your own because you're really interested in a topic, right? Can be stressful, but that's good stress. It's exercising those circuits voluntarily so that when a bad stressor comes along, you have a better ability to respond to it. So I really want to differentiate between the concept of good stress and bad stress, because a lot of our societal thinking in the last few decades, because of the really amazing science that has come out in terms of ACEs and toxic childhood stress, has focused on this removal of stressors. But I think that in order to really foster resilience, a much more critically important topic here is actually, how do we put back really good stressors, right? How do we teach children to want to compete, to want to learn? How do we teach children to exercise those circuits voluntarily so that they are more resilient when they do encounter bad stressors?
Yeah. I have to tell you, Dani, I think I've consumed and read a lot about this topic. I don't think I'd quite heard it discussed in that way. And what you just mentioned of how do we put back in the good stress, and how do we then teach children to deal and cope with some of those stressors? I wonder, for you, Beth, and I know I'm going to ask you a loaded question. I'm just going to say it up front. Knowing about some of this, right? Like, the science, these concepts about, bad stressors, good stressors, and sort of the external context in which many of our families operate, right? How do you take all of that and incorporate it into different programs and actually like start and sustain programs that are actually helpful, right? Like, knowing those concepts, how do you then incorporate them into a program that's helpful to families in different communities?
Yeah, it's a great question. And I love this idea that we want to, certainly not remove all of the stress from families' lives, but rather really empower them and support them to handle stress and go through some of those hard experiences that we know children have to in order to learn and grow and develop and accomplish their goals. So I think when it comes to working with families of young children, the first question always for the family is, what do you need right now? What is most important for you? And we really have to follow their lead. I mean, we do lots of screenings and we ask lots of questions and we come up with our own idea and theory about what the family needs. And I love that we're really shifting toward a much more patient-centered approach of asking the families, what do you think that you need right now? What are your goals? So that's where we start always is, from the family's perspective, what's the first thing that they want to tackle? If we know that there are underlying safety issues or social needs for a family, we know that that's where we have to start. We have to make sure that our families have, a roof over their head and food on their table for their children. We know lots of our caregivers are, forgoing their own food and making sure their kids have enough to eat. So we really need to start there. And all of our programming has to come from a place of making sure that the basic needs and the safety and security of these families are met first and foremost. And often that is what families let us know is their top priority. So we start there. When we have the sense or we have the knowledge that there are adverse childhood experiences going on or have already happened, then what we want to do is, really support the family. Again, at that point, we can't remove the stress, nor do we want to. What we want to do is build up this resilience, and we want to identify. I think we always have to couple the question of what happened with, and what is helping you? What are what we call in healthcare protective factors? So who are the people that help keep you safe? Who are the people that help take care of your child? Where are the places that feel comfortable and familiar to you? So we want to help families not just tell us the story of what happened, but also, let us know what their current protective factors are or how we can help them to develop more. So we work with lots of parents around, how can they soothe their baby? We know that babies respond to all sorts of stressors, hunger, wet diapers, all those kinds of things. We want to teach caregivers how to really soothe and respond to their baby's cues and, let them know that they're safe. That's the major task of infancy, is making sure that babies feel safe in the world and develop this, what we call secure attachment with their primary caregiver. I think Evelyn alluded also to things like routines and consistency and predictability. Those are really simple things that can really change the trajectory of a family. If a child knows when they're going to eat and when their bedtime is and what their bedtime looks and feels like, that can feel very reassuring. And that's a huge protective factor for children, to know what to expect. That predictability, kids just really crave that. And then when we are seeing some of those internalizing behaviors, kids feeling sad or worried, we want to teach parents how to support their child through that, not take it away, not squash it, but, help their child appropriately express that sadness and worry and find, strategies for coping with that. And those externalizing behaviors, we do a lot of work with families about, helping children, again, more appropriately express their frustration and not trying to squash it, but trying to redirect it toward a healthier way.
Yeah. And, I have to say that I have, of course, seen, the work that you guys do, work, right? I've seen your work, in the families that we refer to you. And it really is a patient-centered, family-centered approach in what's happened and what's helping you and how do we help you find the tools and resources, right? So we do have, I think, an important question that came in, and I want to get to it in just a second. I want to ask you just for a moment, Evelyn, about your role as a physician leader in supporting some of the programs that we have available at Columbia New York Presbyterian, such as HealthySteps program, such as the Family Peace program. So I wonder if you can talk a little bit about what your role is as a physician leader in some of these programs, and talk a little bit about the programs themselves, because I think it's important for people who maybe don't have that model yet in their practices, or families who don't know about these models, to hear a little bit about them.
Absolutely. So first, just want to say, as an individual pediatrician, and then I can talk about a leader of programs, but
Yeah.
it's been really important for me to do what I was talking about before: surveillance, screening, that's what we do. And I always use the model of physical health. So every time I see a patient, or for parents, when we're watching our kids, we want to know, how much do they weigh? What are they eating? Did they get taller? And we even have growth charts, right, that we look at every time we see a kid for a well visit. And I think of mental health and behavioral health the same way. There's a trajectory. We have been talking about on this call so far about developmental, healthy mental development skills, the ability of a child to feel safe and grow and learn coping skills and things like that. And so as a pediatrician individually, I try to make it a part of well visits to just do some of that surveillance. How are they doing? And I know we focus a lot on developmental stages. So as kids go through development, we focus on, are they walking? Are they talking? And are they developing those skills? But I always try to at least include one or two social emotional things I can't really see, skills. So are they, soothing themselves? Are they cranky? Are you worried about their behavior, how they're interacting? And ask those questions. It doesn't have to be with an ACEs screen or a specific long screen, but really just to make that part of the individual conversation that we have as we're doing monitoring. And then for the systems, we do put programs in place. We use a tiered approach because this is public health, or we're general pediatricians, so we're seeing all of the children, and as I was saying, monitoring for things. For families who may not even have concerns, we want to catch things early, and when there are concerns, we bump it up to a tier. We call it tier 2 or tier 3. Beth and I worked on a positive parenting curriculum where we're really trying to just utilize balanced approaches to doing some of what we talked about before. And our HealthySteps program does just that. So they're early childhood specialists. Some of them are psychologists, and they're integrated into the primary care setting so that when children come in for their well visits, they can really help us to make sure we're asking about social and emotional health and well-being, and trying to help with skills such as positive parenting, balanced approaches to helping, soothe kids or develop skills, attachment, or self-control, things that as the child becomes a little bit older may struggle with, maybe not. HealthySteps is one example of a program that is throughout the United States in several primary care clinics. And it's really an amazing way to integrate some of this care into the everyday well visits and preventive work that we do. The other one is Family Peace. And so at the other end of the spectrum, when there really are concerns and we've tried to, catch them early, identify them, and provide some support and guidance when things are a little bit awry, when we really reach a point where there's more intensive care needed, we do have a Family Peace program, which stands for promoting early addressing early childhood adverse events and promoting positive events and coping mechanisms. And that's a trauma treatment program. And also mental health providers do, I can talk about it later, evidence-based models to spend a couple of months with the parents and the child to really get at the root of what maybe happened and look for what's strong, the resilience factors that can be built up with a little bit more work. And that's a referral program. And so those are the spectrum of programs that we have. And my role is just to look for it, have conversations, be open to finding things that families may want help with, and then referring when we can.
Yeah. And I think, it's so important for us as primary care pediatricians. I think if we don't ask very often, we just don't know, right? And that in our practices has taken the form of screeners, of course, but I think it also helps us, obviously, a huge amount. I think it doesn't necessarily replace the asking piece, right? Like the talking and knowing that these things exist and these programs exist to help our families. I think it's a really good, yeah, go ahead, Dani.
I just wanted to also mention something that my program is working on now in partnership with another really amazing national program, which is Reach Out and Read. We have now partnered. So I'm the director of something called the Nurture Science program at Columbia University. And we have now partnered with Reach Out and Read National to bring something to the pediatric practice that might seem really silly. Like it might seem like we all should already have this as part of our pediatric toolbox, but it's just that simple. How do you evaluate a relationship between a parent and a child, right? So we've all kind of touched individually on the importance of that relationship. And yet it might surprise people in the audience who are not pediatricians that we are not really taught how to spot these relationships as general pediatricians. It's not something that we're taught in medical school or residency, right? And yet there's a big national movement. The American Academy of Pediatrics, the AAP, has now put out a statement in 2021 of the importance of these early relationships, or early relational health is what we call it, and how this might really bring this into the pediatric practice, might be a resilience building tool, right? So we're at the very beginning of this work. We've just conducted our first pilot of a very short course. It's only a 45-minute online course that was offered to a select group of Reach On and Read pediatricians, about 150 of them, to teach people how to spot so Beth mentioned earlier secure attachment. We're working on a different concept, which is emotional connection, which is this very dyadic concept of, in the simplest term, I try to describe it as a magnetism between a parent and a child. And we're having really good results in this initial pilot. We're now continuing to develop this and hope within the next few years to be able to spread it through the Reach On and Read network, which contains over 6,000 practices across all 50 states in the US.
That is so exciting. And I'm so glad that you share that. And I can't wait for us all at Columbia to be able to take this and learn about this, because, I have to tell you, now that I'm a mom, I have a 2-year-old, there's so much that I feel like I can spot quickly when it's there, right? Like if there's like an obvious interaction, an obvious thing, like I'm like, oh yeah, I'm so good at spotting that. When it isn't, though, I feel like there's so much nuance and there's so much that we're not trained to spot, or to sort of go deeper into and really quantify, etc. So I'm excited to hear that, Dani, and I hope that we can take it ourselves soon here. So I do want to transition to an important question that came in our Q&A, and please send our questions as they come up. So it is about children who are exposed to situations that create severe stress / psychological trauma on a population level, right? So children that are affected by chronic issues like persistent poverty, or children who are caught up in the aftermath of major disasters, migrancy, war, realities that test a child's or a family's pre-existing capacity to manage high-level, more persistent stress. And I think maybe we can break it up in 2 parts. And maybe first I'll go to you, Dani. Do you think about that differently from a biological standpoint? This more population level, severe stressors that can affect children sometimes?
Are we talking like pandemic-related stressors?
Pandemic-related stressors, war-related stressors, migration-related stressors, right? That affect whole populations of children. And I guess, and I'm making this up a little bit because I think the second part of the question was a little bit more direct, but I'm just really curious what you think about, whether that's different in the way that our brains and our bodies respond.
So, absolutely different. But it actually my answer from a biological perspective might surprise you, which is that in some ways, the population level can actually lead to more resilience building. And that's because of this synchronization of the stressor across many individuals. And, there's well-described effects of, I don't want to use trauma bonding because that's sort of a negative connotation, but maybe Beth can help me come up with the positive spin of trauma bonding. But when individuals go through a severe trauma together, they do tend to build that social resilience, more strongly. So while that might, hit you at the individual level, those social bonds might actually get stronger. So I do think of population level trauma as different. Of course, there's also the negative connotation of a lot of people undergoing trauma, and therefore the whole population sort of having that traumatic response. But again, I also think that there's a positive spin on that we can look at from a biological lens.
That's so interesting. And I think the second part of this question is, the audience member who posed this question has been working with children in Ukraine for the past 18 months and is wondering if there are good examples of creative strategies, effective programs that reinforce the ability of kids to get through this type of trauma without causing the lifelong consequences. And I'll ask you that. Is there good examples in knowing and taking into account what you just said, Dani, right? That this is a collective trauma. I'm making up a term too. I don't know if Beth can help us better to do a little bit better with the terminology, but are there good examples of programs that help children as a whole when they've gone through some of these experiences together? Maybe Beth, you can tackle that first.
Sure. I mean, I'll do my best. I think, Dani, as you were speaking, it was really resonating with me. I think, oftentimes what can be so traumatizing about these events is how isolating they can feel for children, that they feel like they're the only one. This is not something that's readily spoken about in their preschool class. So, of course, they must be the only one that this is happening to. And there's so much shame and there's so much guilt that's associated with that. So this notion of it, and I think the pandemic taught us this. Now, listen, there were, there were many horrible consequences of the pandemic. One of the silver linings certainly was this notion, and among school children, we saw this enormously, of we're all in this together. We're all in Zoom school together right now, or we're all wearing masks in the classroom together right now. And so there was this sort of collective sense of, we have to face this together and we have to lean on one another. We discussed that one of the most important protective factors for a child experiencing trauma is having a supportive social network. So, what comes to mind for me in terms of, responses and approaches to supporting this is group therapy. Group therapy is truly magic. And when you bring together a group, and again, it has this social component, but when you bring together a group of, any individuals, but we see this even with young children, who've been through something difficult, when they have the opportunity, we call it altruism in, sort of a group therapy framework, but when they have the opportunity to take care of someone, when something hard that they've been through then gives them the ability to support someone else or let them know that they've been through that also and they understand, that can be really empowering and healing for them. So I think if we can think about those kinds of strategies where kids can share both what was hard for them in these traumatic experiences, but also maybe what they've learned or what's helped them get through, what story their mom tells them at bedtime, what song they sing together. Those are the kinds of things that can then feel very altruistic. And they, again, have this purpose and the sense of belonging.
Yeah. Beth, I don't think I thought about it in the terms that you just described. I always think of group therapy as, you feel supported, you share, right? But I don't know that I necessarily had thought of group therapy as the power of helping somebody else might help you heal, right? Like, I just don't know that I realize that the children and people who engage in general in group therapy are helping other people heal, and that's helping them heal. And I think that's really powerful, and maybe a way that we talk about it with parents, right? Like, as a general pediatrician, if I'm in a position to suggest or recommend group therapy, that can be a point to bring up with families, right? It's like, your child will get to help other kids who have gone through some things, and that's helpful and can help them heal. Evelyn, one more question that came in the Q&A, and I'm hoping you can help us tackle is, what do you see in children with chronic illness in terms of resilience? And is there any specific way that you're able to measure resilience quantitatively? That's a tough one, but I'm wondering if you have thoughts.
So I feel like there are two questions there, really excellent questions, but I think children with chronic illness are for sure undergoing trauma. I mean, we've talked about feeling isolated and not, having that normalcy or those developmental stages and accomplishments through time. But I think because if they have the support of, caregivers and schools where there are, like we just talked about, group settings where they can be like a normal kid and do, whatever it is that they need to do, and not let their chronic illness define them. I think that's where the resilience comes in. So I think that was the first part of the question about children with chronic illness or special needs, and how trauma and maybe resilience would be different. I guess the answer is they're both present, and maybe not so different in the end. The second part of the question was how to measure it. I mean, I think that's a hard one. I know,
Yeah.
and I don't know if the question is asking about tools, because I know as physicians, a lot of what we want to do or feel the need to do, because we have 20 minutes and we have to, get a blood pressure and give a vaccine, is to objectively measure something,
Right.
give a treatment and move on. I think that that's what makes this really hard for us, but I think we need to resist the temptation to do that, because it's just not helpful. I mean, we can do, screens and measure, and I know there are lots of studies, maybe Dani can talk about, where we're measuring cortisol and trying to, find biomarkers to understand how much stress or trauma individuals are experiencing, to then better be able to meet their needs and match the level of intervention to the level of stress that they have. I don't know if in our setting on the ground, aside from the research settings, if we're there yet to be able to utilize those techniques. And more so, it may just be that we use this universal approach, right? To not assume that everyone's had trauma, but or needs, us to have these conversations or provide these treatments, but kind of don't assume the other way either, that everyone's okay.
Yeah.
And just sort of blanket, just say, this is a thing that happens. We're learning so much about it. Measurements, I don't know that we're there yet, or whether it would ever translate into being helpful in like our pediatric encounters that we have. Sorry, I don't have a better answer,
I
though I
definitely
understand the
can
need.
pitch in real quick, Evelyn, that there
Yeah.
are no biomarkers for resilience. That's my entire
Yeah.
research program.
Yeah,
That's
yeah.
what we're trying to figure out. There
Yeah.
aren't. There are some nice correlates, like you just mentioned, the cortisol response. But even then, the literature is extremely split over whether or not it's a really, high response in terms of cortisol that predicts resilience versus susceptibility. There's studies actually showing both ways. And so we really do not have these kinds of biomarkers or any really good tools. Additionally, the problem with resilience is that, again, it's context dependent, right? And so you can only really measure resilience in the face of a stressor, right? So there aren't any good tools right now that are predictive of how people are going to respond during a stressor. That is literally what my program works on, mostly in, like I mentioned, in rodent models, but we are also now conducting longitudinal studies in humans and in babies born during the pandemic, just to start, gathering a lot of this kind of information to then be able to look backwards in time, hopefully in the next couple of decades, once we have data on how these children develop, who actually develops things like psychopathology, internalizing and externalizing symptoms is something that we've started to think about right now. And then be able to go backwards in time and see what are those predictive, protective factors for these children. But no, there are no biomarkers even in the research world, much less in the clinical world.
Yeah. Along the lines of data and what we know and where we are, we had a question come in that says that we know that ACEs affect areas of the brain, the prefrontal cortex, the amygdala, the hippocampus. Do we know if increasing resilience can reverse those changes? And I'll pose that to you, Dani, as well.
I think the data is beginning to emerge that the answer is yes. Although I want to be cautious, because it's not really increasing resilience. There really haven't been truly proven ways to increase resilience, but certainly resilience is associated with protection of those brain areas. So for example, in animal models, we see things like loss of synapses. Those are the connections between neurons in places like the prefrontal cortex and hippocampus. But if you then subdivide those animals into susceptible versus resilient, it is only in the susceptible animals that we're seeing those changes, right? So the resilient brain kind of has a protection in place. But in terms of do we have true ways of increasing resilience? No, that's a very active area of research. It's really at the very beginning of that kind of research in the past decade. I would say that the neurobiology has kind of moved into this strength-based conceptual framework that is very novel.
Yeah, it is so interesting, and I hope that in a couple of years we can have another conversation and you can sort of tell us where we are and what we know. But definitely fascinating and important questions to be asking, right?
I feel, just to say, I know we focus on early childhood because of the plasticity, right? We always talk about the plasticity of the brain, but I have a specific interest in school age and teenagers, and even us, right? As adults, we're constantly learning new things. So we may not be able to reverse the effects, but there's definitely plasticity way beyond age 2. Although we should focus on early childhood, I feel like there's still a lot that can be done throughout development.
Yeah, amazing. To transition a little bit into tools for parents at home, right? Both for the parents who are listening and the clinicians who are listening and are hoping to then share some of these tools. I'll start with you, Dani. How do you think we can begin this work of fostering resilience at home? Knowing, again, loaded question. What do you say is where we start to prioritize, and how can we be intentional in fostering resilience?
Well, here too, I'm going to provide a little bit of a counterintuitive answer, and I'll just give, so first of all, there is no one panacea, right? There's not one answer to this question, but I'm gonna provide just one simple rule, and it's gonna be counterintuitive, and that is stop trying to do so much, right? Like we're constantly being bombarded with like everything that parents have to do, and it's exhausting, and that places stressors on parents, and then you're constantly feeling that you are not a good enough parent, and then you feel guilt, and then that interferes even more with the relationship. The reality is children don't need that much. Stop buying them toys, stop trying to fill their schedule, allow them to have that time by themselves, provide them with lots of playtime with simple toys, and preferably outdoors, preferably with other children. And that will exhaust you less as a parent, and it will certainly help them develop. Again, it's those circuits that they're going to practice on their own with intentionality, which happens during play. And this has been well described, not just in humans, but also in every animal model and every mammalian animal model, that play that happens early in life is super important to brain development, to resilience building. So yeah, stop doing so much.
Yeah. So I love that answer. As a mom who's been bombarded with all the things that I'm supposed to be doing, right? Like and I thought I would be immune to this because I'm a pediatrician. And so like this wouldn't get to me. It definitely got to me, right? This pressure and this feeling that I'm not doing enough. And I'm going to make a shameless plug for one of the episodes of our podcast, although I think the whole podcast series is great. But we spoke with a longtime developmental pediatrician from Columbia who recently retired, Dr. Harriet McGurk, known to many of us, who said the same thing, Dani, like stop trying so hard, it really is about showing up and being present and enjoying your children and allowing the time for that enjoyment. I'll pose the same question to you both, Beth and Evelyn. Where do we start at home, and what's your take and your quick tips? I'll go to you first, Beth.
Sure. Sometimes I think it's so silly. I've been doing this work for 20 years, and where I've come to is such a similarly simple answer. I just think we need to take care of families. We come up with all of these programs and strategies for doing it for them. And I just think what we need to do is, give the families the resources they need, and they are so much better able to take care of their children. So that's been a, really big clinical shift for me, is no longer am I the one trying to help their child. I'm trying to help them help their child. And that to me feels like an important distinction. So certainly there's things like making sure that, parents who have mental health needs or substance use needs get those treatments, all of the social and making sure that all of those needs are met. I think that's where we need to start. Again, I think I think about it so silly. My doctoral research, where it all pared down to, after doing work with several families with young children, was bedtime stories and dance parties, and that was all really families needed in order to, build these healthy, secure attachments and have this special time together. And it was, while you're cooking dinner, while you're giving them a bath, sing a song, have a little dance party. That is what is going to really have an impact. Don't worry about all the other stuff. I also think, Dani alluded to this, we want kids to just be playing. We want them to have safe, healthy places to do that. Playgrounds and libraries and schools and, early childhood education centers, all of that is definitely needed. So I think at a systemic level, we have some work to do and some advocacy to do. But I think the answers are quite simple when we come down to them.
Yeah, I love that.
Can I just put a plug in for systemic level? Can we put back breaks in schools? What happened to breaks? I mean, I had breaks where I could play cards in school. My kids have to run from class to class. So that's a simple systemic change that we could make right there.
Let's advocate together. I'm always up for advocating together for these solutions that are evidence-based, right? So I think we can find some evidence to back that up in addition to our shared expertise. Evelyn, what are your thoughts?
I just think this is great. I love this. I mean, I think that you just mentioned schools, Dani, and it's true. There's a lot of research now talking about how academics, there's so much focus on academics, but is really not the focus of child's health and child development. And there really needs to be at least half of what the child is doing in school, non-academic, just interacting with peers and learning these other social and behavioral skills. I think at home, just letting the child take the lead. So I mentioned that positive parenting curriculum, and people, ask like, what's positive parenting? How do I learn that? What do I do? Not to say that you need to follow a regimen, because it's true, do less. But just what I've learned about positive parenting is just really letting the child take the lead, letting them learn for themselves. Example, like tying their shoe, because of course, in doing so, they're gonna learn those brain connections, and that's gonna serve them so much better, as opposed to us as parents and as pediatricians. We always feel the need to jump in and help them and teach them, right? And then discipline is the other half, but it's really just about teaching. And I'm learning all these new words like scaffolding and like being there, providing them with some examples, modeling, and then letting them figure it out on their own. And that's hard to do as a parent and as an adult who thinks, I've already learned this, let me just show them what the right way is. So less is more, I guess. And that's,
yeah. I love this. And it all really boils down to, being there, being present, and allowing your child to be at the developmental level in which they currently are, right? And sort of embracing that. Beth, to talk a little bit more system level again, although we've been talking about it, what else do we need to be doing to support parents? Is there anything else we haven't yet touched on that you think is important at a system level to empower parents to do the simple things and to be able to meet their needs so that they're able to do the simple things in their homes?
Sure. Yeah. I mean, I think from a healthcare perspective, some of the important systemic changes, some have started to happen. So, recently in New York State, Medicaid insurance for pregnant patients was extended through 1 year postpartum. It used to be 6 weeks postpartum. And so, moms after delivering right at that 6-week postpartum visit, many would lose insurance at that point. And I mean, what other example is there of their not being able to take care of themselves? They don't even have insurance to, continue to seek out their own healthcare, when we know that's the point at which many, for example, maternal mental health difficulties might come into play. So that is an important change that's happened in New York State. And I hope we can continue to advocate for all parents to have health insurance. I mean, that to me feels like a real human right. Similarly, as it relates to healthcare, there is a big push now. So Evelyn mentioned our HealthySteps program, which is among the most evidence-based programs in the nation. Where we struggle is reimbursement from insurance companies. So that dyadic work, meaning working together with the primary caregiver and the young child, is what we're doing, and that's where the science really shows the power is. However, that's not reimbursable by insurance right now. So There's a lot of efforts up in Albany and around the country to, really improve reimbursement rates for that type of work in healthcare. And then we all spoke, I think, about some of the other things at a systemic level that I think we need to continue to push for. I think every child deserves access to really good early childhood education. We swung in that direction, I think, with universal pre-K in New York City, and I think 3K was similar. I'm a little disheartened to hear about some budget cuts and things like that. I think we have to continue to fight that those are not luxuries. Those are not add-ons. Those are absolutely necessary and should be accessible for all children, because the science just shows, the return on investment in those kinds of programs. We need grocery stores and playgrounds and libraries and all of that in all of our communities. So I think we just have to keep going out there and letting the science speak for itself, and trying to get the money there to then support all these programs.
Yeah. Again, let's advocate together. Knowing what we know and how much our families teach us about what's important and what matters, we can definitely advocate together. We have a couple of minutes for questions. Evelyn, I want to ask you one last question, but for people in the audience who are listening, and we're so grateful you tuned in this evening, please send us any last minute questions that we can address in this last couple of minutes. But Evelyn, I did want to ask you, we've had what I think is a really hopeful conversation this evening, right? Of where we are with the science and what we've learned about best practices and how to be family centered and empower families. I also want to ask though, what do we do, or what can families do when things aren't going well, right? Despite your best efforts, despite, good programs in place and pediatricians who care very much and who are informed in this work, things sometimes don't go well. Where do you go? What do you do when things are just not going well?
Yeah, it's a great question, because we all know there's a shortage of services, including pediatric and behavioral health services. I mean, I think just finding sources of support socially, and whatever that means. We talked about family members, church. There's a lot of social service organizations, especially that we work with here at Columbia, who are open, at least Monday through Friday, if not Saturday and Sunday, specifically to have people drop in, to provide groups. It's unscheduled, sort of mommy and me groups. Someone mentioned before the library. So don't stay at home, go out, seek support in others, because we talked about the importance of affiliate responses. And then, the pediatrician, we're trying really hard. I know there's a lot of pediatricians on this call to do this work. It's hard, but just seeing the pediatrician often, and for those pediatricians, just seeing the patients often. I mean, I always feel like we do that for, weight checks, and we do that for, other things, asthma checks. And so just seeing the patient, having a visit just to check in, reminding them that we're here, that things will get better, that we can problem solve together. We can try one thing. If it doesn't work, we can try another, do homework together. This is not an easy fix. There's not a quick prescription. And then there are very long wait lists. There are like Family Peace Program and other behavioral health programs that really do focus on maternal child psychotherapy and behavior modifications when there are issues with behavior. There are also hotlines that folks can call, both pediatricians and parents, to sort of ask, is this normal? Can I, get on a wait list? Or mostly for pediatricians too, to get guidance on diagnoses. Is there a diagnosis to be had? And if not, what do I do in the meantime while we try to figure this out, whether it's a medication prescription or something else? Yeah, and it's hard work, but just patience. And we all in this business, and as parents, we do this because we love our kids, and having that hope and knowing that things will get better gets us through. We have to build our own resilience in that way.
Yeah, I love that. And we didn't even touch on our own resilience as parents, right? Which can be a topic for another evening. But it's so important. Thank you to all our panelists. It's really been such an interesting conversation, such a fun conversation. We hope an informative conversation for people who tuned in. We're so grateful that you tuned in. We will be sending out a recording of this webinar over email, as well as some resources after tonight's webinar. We also just want to remind you, please sign up for the CME this weekend. It is going to be an amazing lineup of experts sharing the latest in pediatrics. And tune into our podcast, The Stuff That Matters for Kids' Health. Follow us on social media. And thank you all so much. Thank you, doctors, for joining us this evening. We'll see you. We'll be sending out an announcement on the next webinar and dates very soon. Thank you all so much.